In collaboration with our group, we have created a feasibility proposal to solve inefficiencies we have identified in the healthcare system.
You see, as it stands, there's a significant problem in a variety of emergency and medical departments, but more commonly in smaller local providers' rooms, as they usually have less staff and less room and less funds. And that's generally just the mismanagement of what limited resources they have. This means that whatever nurses or doctors may be working on a specific shifts are not being handed patients in a properly efficient way, and as such, less people are being seen fast, and this causes a variety of problems, including people being mistriaged and being ignored or put at the bottom of the metaphorical food chain. And this could go on in perpetuity depending on the day, because every emergency department also works as an urgent care room for some populations. And that means if, for whatever reason, you have to go to a more local provider's room, then it's going to take a long while if you need to get a prescription filled, or if you have a minor medical problem that needs to be addressed, but because you're going to an emergency department, everyone who's having an emergency will always be treated first. And this means you're being sat there and you're being assessed, and so you probably have to wait anywhere from a couple of minutes to a couple hours if you're willing to wait that long. And sometimes there's absolutely no way to tell, so it just becomes a problem that insists upon itself, and it's a self-fulfilling prophecy of sorts. And what this means is that a lot of patients are putting themselves at risk for improper medical care, because the longer they wait, the more impatient they get, and the more impatient someone gets, the more likely they are to just leave. And it's one of the biggest problems with giving healthcare at the moment, is that if patients are completely allowed to just refuse to be treated for whatever reason. And one of the biggest reasons that they usually have is that it takes way too long. They don't have the time to sit there forever waiting for a doctor's appointment when they have work or school or family to attend to. And so with this, we hope that we can find a solution that makes it so that those wait times get down and these people manage to get the appropriate amount of care.
The proposed solution to address overcrowding and inefficiency in the emergency department is to implement a room in the front of the clinic. This will be dedicated to non-emergency cases, such as flu-like symptoms, prescription refills, and doctor's notes. This room will be staffed by a provider who will be assigned to focus solely on these cases during their shift. This will allow them to see more patients than current capacity allows. To ensure the provider isn't overwhelmed, a smaller support team will assist them, and triage nurses will be better trained to accurately categorize patients as either emergency or front room quick cases. Providers in the urgent care room will be expected to see 25 patients per 9-hour shift, and a monetary bonus will be offered as an incentive for meeting this goal. Expanding the space and optimizing patient flow will reduce wait times, alleviate stress on emergency providers, and ensure that patients receive timely care based on the severity of their condition.
All right, so we're going to start this off. This is plan 2. So this is creating a brand new building that we are designing ourselves in order to function as a faster clinic with less wait times. And that involved moving a lot of the patients to the second floor to first eliminate those hall beds that we see in the first floor plan and in plan 1. And so by making a new building, we're able to really establish a workflow that we think is going to be beneficial to a higher amount of patients as the clinic grows, and is amendable to more or less providers. And so to get started off, we're just going to look at what the patient would see first, and that's the bottom left box. That's going to be a light orange box, and that's your triage check-in area. As the patient walks in, the first thing they're going to do is they're going to talk to that patient at or the person at registration. And then they're going to talk to a nurse, and the nurse is going to triage them. Now, the nurse has gone to school for 4 years. They've likely been doing this a while. They don't normally put new nurses on the triage, definitely not their first day. And going into that in more depth in the plan is that these nurses would be further trained. And what you see a lot of times in healthcare is that it is busy, it is fast-paced, it doesn't stop. And a lot of times training is pushed under the rug. You get those online training manuals and courses that most of the time you just skip through because the quizzes are, you can take them 10 times and it's no impact on you. And you wouldn't want it to be. I mean, it's a mandatory training that you have to take and you're on the clock for it. So you just want to get it over with. But in a perfect world and a situation where we would want to prioritize those trainings, so we would want a one-on-one training opportunity, and maybe for that to reach out for a month or two. So the nurse who is new to this clinic, maybe not a new nurse, a nurse new to the clinic is able to see how things run, how we want things to go, where everything is at, and a lot of those finer details that are missed by those online courses. And so that's going to be our first box, is the light orange box where the patient checks in and gets triaged. They get moved to the first floor, which is the emergency department, or the second floor, which is the urgent care. And so this first floor is mainly for patients who have some kind of serious, they have a higher probability of getting admitted after their tests are done. They maybe have something like appendicitis, they maybe had a stroke, they had a myocardial infarction, their health is deteriorating at a rapid rate, and it's classified as an emergency room visit because they have some acute issue that needs to be taken care of urgently. An urgent care visit on the second floor, on the other hand, is something maybe more chronic. So they come in with back pain, or maybe they fell off a ladder and they hurt their ankle, and that was done last week or a month ago, or maybe the back pain's been going on for 4 years. They're not in really any high chance of dying. And so while we want to take care of every patient, those patients are going to wait longer than the patients who are actively dying. And so we would want to move them to the second floor so they can be seen by the providers whose goal isn't to save people that are actively dying. It is just to treat patients as they come in, first come, first serve. On the first floor, it's much more who needs to be seen first based on the acuity of their condition. And so going through that light gray box in the top left of both images is indicative of the staircase. So I've set it up so that if you see there's that clear path between the first floor and the second floor main rooms, where a patient who may have been moved to the second floor despite the training that we've done maybe has an acuity that has gone up in their stay at the emergency room. And so we would want to move them back down to the second floor. Now, there is a likely chance that this would need to be done quickly if such a thing happens and arises. And you would want them to just go straight through that pathway to a room on the first floor. And then looking more closely at that image on the left, we've gone through the light orange box. Right to the right of that is the dark orange box, which is the laboratory. So this is where you would get blood tests done. This is where you would get your urine done. This is where you would look for liver panels, a BMP, a CNC, and all those different kind of blood works. And that's where this would be done. You would have a lab. In the clinic right now, it's actually a smaller room, but with more room, it's more efficient. And a lot of times things get lost, things get misplaced in the lab. And so it's nicer to have that more space for the lab person to function correctly. Going more to the right of that, we see this light green room, and that's going to be radiology. This is where our CT is going to be. This is where the x-ray is going to be. This is where those techs are going to be. Now, radiologist would not be in clinic. It would not be a place where the radiologist would be able to function, but that is normal for a clinic like this. And you would want to send these images off to a radiologist to read. This does tend to take some time. And so those radiologist techs and the ultrasound techs and the doctor are able to look at a reading and say, this is what I think it is, and I don't think you have any major acute things going on right now. Now, you would often want to wait longer based on the clinical standing that the provider has judged. So that is really up to the provider's clinical judgment, but that's where the radiology room would be. These dark gray boxes that you see everywhere are the patient rooms. So as we see, we have the larger rooms in the first one in order for more space. Definitely during a highly acute trauma, you're going to meet a lot of people in the emergency room as a patient if you have a trauma or if something goes wrong while you're there. And so you want that space for that amount of specialists to go in the room, if that makes any sense. So that's the space that you would that the patients would be in. In the second floor, we see them a little smaller. There's not going to be that many people in there. Maybe one nurse, maybe the provider, but really just one person at a time. And so moving inward, in both of these images, you see those long, dark gray bars. And those are the workstations for the nurses and the providers. And so either way that you set those up, normally the nurses would need more room than the providers. But the clinics I've worked at, it's normally the providers on the bottom, the nurses on the top. And so the nurses all stick together, the providers all stick together, they talk, they communicate, they've established some sort of kind of professionalism that goes on between them. And so we see that going on here. And then going on to that first image, we're missing that yellow box in the top left, which is going to be for storage. And so there's a lot of things that need to be placed, and under the stairs and out of the patient's way is probably the best place for storage to be. And that is one of my main criticisms about the initial clinic, is that the storage is right there along that wall where the patients can kind of see and get to. So I made it a point to tuck that away in the corner. Then moving on to the second image, there's that light blue box in the bottom left corner, which is the pharmacy. This room was put in specifically because a lot of patients will leave the clinic and not make it to a pharmacy. There's a lot of times that patients will recheck in after a week saying their symptoms have worsened, but they haven't picked up their meds. And so while the providers may have all the knowledge and capability to help a patient, if the patient is not ingesting the medication that the providers prescribed, they're not getting better. And so that right there is for just an option for patients to pick up their medications from, whether or not that pharmacy is, and it would have to be a different company. Per law, it can't be the same company that the clinic is. So it's kind of a room for rent for whatever pharmacist would go in there and work. It could be owned by the same owner as the clinic. It would just function as a different business. I'm not going to get into the law of it right now, but that is an option for the patients. The patients can and should be able to say, I would like to go to my own normal pharmacy next to my home, my own Walgreens that I normally go to, and that would be an option as well. But I think that it's ridiculous that we don't have pharmacies in clinics as it is. So there's an option for the patients. And then next to that is that dark blue, which is another lab. This one has space. Honestly, the labs are all done electronically now. It could also be hey, let's get this to the lab upstairs for the first floor, and okay, we'll get this done for the second floor. And that's just another space for a lab, because that walking up and down the stairs, definitely for those COVID tests, flu tests, strep swabs, we would want to just get those done on the same floor, no traveling back and forth. In the main hospitals, they do have vacuum systems to send those to the labs. That is an option if we wanted more space. This is a conversation that we could definitely have in the future. But right now, without that added increase in expense, I decided just to have 2 spaces for labs. Yeah, and so that's kind of the images going through them, and that's the plan too. We want to make a functioning clinic that prioritizes efficiency, comfort, and quality. By adding some more rooms, a pharmacy, and a dedicated provider, we can follow all the laws and regulations of the state and accomplish the goal of healthcare that the patients want to seek out.
As far as costs go, obviously with two plans, there are two different cost breakdowns. Solution one obviously being the cheaper, as it's the more simple solution. You see, with solution one, the only thing we need to really worry about is hiring a provider and then making sure that their training is done. And so we estimate that about 1 month's cost for hiring a provider, that should be around $75,000, which is calculated from specific bonuses and the percentage of their yearly salary, obviously taken for their paycheck. And then the training, which we have understood to be around $110,000. And that's a lot more expensive because, well, that's a whole team effort. Hopefully we hope to make it so everyone is well trained, and it sticks, and for that it's usually going to cost a little more. It's going to be a little more expensive, but the hope is that it's a less common occurrence and a less common expense that only needs to happen rarely, instead of constantly needing to retrain professionals and then still hoping that they manage to get it right. Meanwhile, solution two is, well, as you can see, significantly more expensive, but there's a whole lot more that goes into it. It's a more complex plan, but we believe the investment to be worth it. So obviously, we need to now hire a team for the new pharmacy, and we estimate that to be about $100,000, because we need a pharmacist and then around 2 techs, and plus a myriad of other small fees like recruitment and hiring and all that. It usually averages out to about $100,000. And that's also why the training has come up just a little bit, because we are adding a couple more people into our staff. So obviously the training, which is still going to be staff-wide, would be a little more expensive in comparison. The main bulk of the costs, however, comes from the price of building a new floor. We took some rough estimates for how much it costs per square foot to add a new story to an existing building. Then we took some simple measurements using the clinic, and it estimated out to be around $4 million, which in all truthfulness is pretty expensive. It seems pretty expensive, but that is the bulk of the cost, is the building, and everything else is pretty inconsequential in comparison. Because, let's see, next is equipment and properly equipping a pharmacy and the surrounding medical facilities. It's only around $75,000 on a average to low end, depending on the size. So honestly, nothing insane. And then obviously stocking a pharmacy, this is the biggest initial investment, but as you stock it, it's a perpetual smaller fee, because you don't need to restock everything all the time all at once. It's smaller increments of whatever it is you're running out of or have already run out of. So the first month should be around $250,000 to stock everything, and then after that it should go down. But to be fair, we're calculating both for the 1 month expenses. So solution one will cost anywhere from $175,000 to $200,000, and the cost for the 1 month of solution two is around $4.5 million, give or take. But we would see both of these as worthy investments, and either plan would be successful, but depending on the budget and how much we're willing to invest and how much time, obviously one solution may be better fitting for a certain pharmacy or emergency department rather than another.
I will now talk about the benefits for both of these plans for clinics. The first of which is consistent treatment. By reducing the burden on each provider taking care of the patients, they are able to provide more consistent care, focus, and energy to each patient to ensure that the whole experience, the whole treatment is overall better quality. And the second of which is with these changes, patients will have to wait less time and therefore expect better outcomes, to which this benefits both the community and the clinics as a whole, because now people will be more inclined to visit clinics and get the treatment there. And of course, since now the workflow with these plans, the proposed workflow will be better. Therefore, the providers, the doctors, the staff will be able to dedicate and personalize each patient's cases and focus more on areas which were previously underserved. But of course, aside from benefits, there are also obstacles to these plans. For example, for the first plan, there's by allocating a provider to the front to receive patients, you receive less staff within the treatment area, which may cause some trouble in the work efficiency, especially if the provider is a trained professional. This, of course, can be solved by just allocating newer staff to the back, but of course, this leads to a second obstacle, where, of course, in order to ensure that the workflow is not disturbed and the treatment is consistent, you have to train these new staff members up to the par of the current members, which requires a whole lot more resources than just simply not allocating providers to the front. As for the second plan, whether it's building another floor to the clinic or building a clinic overall, it's financially demanding. It's expensive, of course. With tearing down existing infrastructure or just adding on new ones. And in addition, even when there's these new locations, you guys still gonna need more staff to take over this location and look over it, and as well as requiring them to be sufficiently sufficient to staff them, have experience.
And so in conclusion, we're going to be faster and more accessible healthcare, and the community should be more inclined to visit their local clinic. Especially here in New Mexico, a lot of times healthcare is overlooked because we just don't have a lot of providers. And so with these changes that ensure a faster amount of service and lower wait times, we should make the community more inclined to visit the local clinic. Our doctors are going to be able to focus on their patients without having to worry about receiving an excessive amount of patients, thus improving the accuracy and safety of each diagnosis. Each individual patient will have their problem thoroughly examined by the doctors and providers. Severity of cases should no longer have an effect on wait times, and the providers will have the ability to focus constant attention and care to each patient. A lot of times we see incentives and bonuses being given to providers that see more patients, and this is a great way to effectively motivate these providers to see more patients and to get more patients cared for. However, a lot of times this leads to a lower amount of accuracy and a lower amount of attention given per patient. And we don't want to sacrifice efficiency and quality for speed. And so just allowing the workflow to go more easily would have a way better effect on the provider's ability to care for each patient. And this is not to say that every provider does this, and it's not to say that there's providers that don't take special care per patient, but it's just a fact that we want to make it easier for them. And so in total, all these changes and everything are going to make wait times significantly less. And if you visit the clinic for a minor problem or a more severe problem, each case is going to be handled with an increased amount of care. And so going forward with these changes, you're seeing all these things take place, and it's going to make it so that the healthcare here in New Mexico is more seen as a positive and less as something that is negative. And you know that it's bad when every healthcare person in New Mexico knows that the healthcare here is not up to standard. It is subpar. And the patients know this as well. And it's definitely reflected in how long it takes to be seen for every specialty, including primary care, clinic, and emergency department visits. So, in conclusion, this is just one step, and it's the correct step to make sure that we're seeing and caring for the patients and the community of New Mexico. Thank you.